So these are my disclosures. So the case I'm presenting is a 54-year-old female patient with end-stage kidney disease secondary to hypertension. Of note in her past medical history, she had low viral load hepatitis B. And of note also, she had a hospital admission requiring an HDU stay with COVID at the beginning of this year. This was her medication history, nothing of note there, some antihypertensive medications and anti-Hep B medication also. From an access point of view, she had a left brachiocephalic AVF that was formed in November 2020, and she was commenced on hemodialysis in February 2021. And again, I just want to sort of, in full sort of transparency, this patient didn't have any flow volume measurements or duplex assessments subsequently in the lead up. And, I guess it's an excuse, but, perhaps COVID played a role in that. She had been seen in a renal assessment clinic in April of this year, where she was noted to have good blood pressure control. And the hemodialysis adequacy was pretty good. She had a urea reduction rate of 78% and a KT over V of 1.74. She'd had 3 times a week, 4-hourly treatments with good pump speeds, with no reported issues at that stage. Unfortunately, she presented about 3 weeks later with a thrombosed access, and her duplex picture shows the extent of the thrombosis from just past the anastomosis all the way to the cephalic arch confluence. So as per our routine at our institution, she came to have a fistula thrombectomy. Also I wanted to add that she presented on the Thursday. She was assessed on it was a 1-day history of thrombosis, Thursday into Friday, and her procedure was on Monday. So the thrombectomy is done on day 3. As per routine, we crossed the area of stenosis, and it was quite difficult to get through the needling segment and the cephalic arch. Once we were in the central veins, we established that the central veins were patent. We administered 5,000 units of heparin, and we used the angiojet using the power pulse, leaving a dwell time of 20 minutes, and then performed a pharmacomechanical thrombectomy. Having done the thrombectomy and the fistulogram revealed a high-grade stenosis of the cephalic arch, and a little bit like your case yesterday, Bart, I was quite concerned that this might rupture even with fairly low diameter balloon angioplasty. So I opted to put a covered stent in the segment and post-dilated it and established good outflow into the cephalic and subclavian veins. Having done that, we established reverse access going into the proximal brachial artery and repeated the process with the thrombectomy. But having done that, and then following that with a balloon trawl and angioplasty of that anastomosis and complete balloon trawl, I just could not establish flow into the fistular vein and clearing the needling segment. So we did a repeat balloon trawl angioplasty, and having done that, we were able to establish flow going into the anastomosis and that first segment of fistular vein, but the thrombus in that needling segment was just very resistant and just would not shift. So the further maneuver we did was, given that it hadn't responded to pharmacomechanical thrombectomy, we went with balloon angioplasty, and here we've used a 12-millimeter balloon, sized this to the diameter of the vein, and to hopefully get any of that sort of fibrin-rich material against the wall. But despite doing that, I just could not clear that very resistant hard clot in that needling segment, despite the venous outflow being okay. So, and at this stage, having done this for about sort of 2 hours, I was out of ideas at this stage, I must admit, and I did stop. So the problem here was that I just could not clear the cannulation zone of that thrombus, and I really don't have a complete idea of what that could be. I have some sort of clues on it, but this is just to ask yourselves and the audience for any advice and any help should I face with this sort of case in the future.